Hi, my name's Aaron McDonald. I'm an anatomy lecturer at La Trobe University, and in this clip we'll be looking at the elbow joint. We're probably all aware of where the elbow joint is, but to be more anatomically descriptive, we can say it is where the forearm articulates with the arm. And to look at the bony landmarks, here we have the humerus of the arm. So we're looking at the distal humerus, and we can see some articulating surfaces, the capitulum. Caput means head, so if someone has been decapitated, you may have heard that term, so they've lost their head, so caput is the head. So this round structure here. Trochlea means pulley, so this is another articulating surface of the distal humerus. This trochlea is articulating with the ulna of our forearm. So the proximal ulna of the forearm, this trochlear notch, is articulating with the trochlea of the humerus. The head of the radius is articulating with the capitulum of the humerus. So try to familiarise yourself with these bony landmarks around the distal humerus and the proximal radius and ulna. You may also have learnt about the knee joint, which is homologous to the elbow joint. However, be aware that in the lower limb, the femur articulates with the tibia only and not the fibula. However, in the upper limb, we have the humerus articulating with both bones in the forearm, the ulna and the radius. Looking at the bones involved and the joints, we have two joints as it says here. We have the humero-ulnar joint, obviously between the humerus, the trochlear portion of the humerus, and the ulna. And we have a humeroradial joint is between the capitulum of the humerus and the head of the radius, this concave aspect on the proximal portion of the head of the radius. Histologically, the elbow joint is considered a synovial joint as it contains a joint capsule, a synovial membrane, and is bathed in synovial fluid. Functionally, the elbow joint is a hinge joint. The elbow joint moves in one plane only, so we call it uniaxial. It moves in the sagittal plane, and the movements that are occurring are flexion and extension. You may have noticed that when people are standing in anatomical position, the forearm is projecting slightly laterally relative to the arm. And this is what we call our carrying angle. Another term for carrying angle is also valgus angulation. Valgus meaning where the distal structure, in this case the forearm, is projecting laterally relative to the proximal structure, the arm. And it essentially is formed due to, we see here, the medial epicondyle, a larger prominence than our lateral epicondyle of the humerus. Our medial side here, we see the medial aspect of the trochlea projects more distally than the lateral aspect. So it projects more distally, pushing the ulna out more laterally. And this creates this carrying angle. And a number of studies have been performed over the years to try to determine what is the cause of this carrying angle, and some studies have defined gender differences between females and males. Other studies have found no difference. There's a non-dominant arm has been said to have a greater carrying angle. Other studies have found there's a greater carrying angle in the dominant arm. It's been studied relative to height. Some studies have found that it's inversely proportional to height. Others have found no difference. So at the moment there's a lot of conflicting results relative to this carrying angle, but overall we can see that we do have this carrying angle which varies between individuals. I do want you to have a think about this last point. The carrying angle will disappear when in pronation and also during flexion. So I would like you to think about these reasons as to why the carrying angle disappears, and post your answers on the LMS. The joint capsule of our elbow joint encapsulates not only the humeral-ulnar joint and the humeroradial joint, but also our proximal radio-ulnar joint. And again, this will be covered in a later clip. So just giving you some anatomical attachment sites for our joint capsule. Just above the coronoid and radial fossa, so our coronoid and radial fossa. Distally along our margin of the coronoid process, and so these are a few bony landmarks that you should familiarise yourself with as you are studying the bones of the upper limb. Laterally, we have the attachment of the capsule to what we find here, the annular ligament, again looking at this more specifically in the radio-ulnar joint film clip, and our lateral collateral ligament and a medial collateral ligament, which we'll look at in the next few slides. The joint capsule is found to be weaker anteriorly and posteriorly, however it is strengthened medially and laterally due to the lateral and medial collateral ligaments. So looking at these ligaments, the two main ligaments which help stabilise the elbow joint, we have the medial collateral ligament, so this is a medial view of the elbow joint. And while we're discussing the medial collateral ligament, you may have heard the term valgus or varus stress. This is another point I would like you to think about and answer on the LMS discussion board. So when we're thinking about the medial collateral ligament, what forces or stresses would the medial collateral ligament be restricting? Would it be valgus deformation or valgus stresses, or would it be varus stresses that the medial collateral ligament is restricting? So think about this and post your answers on the LMS. So the medial collateral ligament has three main parts: an anterior band, which is the strongest, it's a cord-like structure. We have a posterior band, which is a fan-like structure, and in addition to stabilizing the medial aspect of the elbow joint, it can also limit extension. And we have this oblique band, and this essentially deepens a socket for the trochlea, so it increases the congruency and the joint cavity of our elbow joint. We have a lateral collateral ligament, and this is, again, try to think, does this restrict valgus or varus stresses or deformation? And post your answers on the LMS. As we can see, it's a fan-like structure from our lateral epicondyle, and this inserts onto our annular ligament. And the main point between our lateral collateral ligament and our medial collateral ligament is our lateral collateral ligament is inserting or attaching onto the annular ligament. It does not continue on and insert or attach to the radius. This is very important. If the lateral collateral ligament attached to the radius, we wouldn't be able to perform supination or pronation. Or if it did attach to the radius, it would have to be very, very loose to enable us to perform supination and pronation, and therefore would be functionally useless. So the important point here is the lateral collateral ligament is inserting onto the annular ligament of the radius. We've looked at previous film clips where you've seen muscles found in the arm. We have anterior muscles. Try to reminisce what were the muscles we found in the arm and the anterior arm, and what were the muscles that we found in the posterior arm, and what were the actions that they performed on the elbow joint. So looking just quickly again, reviewing our muscles of the arm. We have anterior muscles. They're crossing the elbow joint anteriorly, and therefore we'll be performing flexion at the elbow joint. So we can see we had our biceps brachii, long and short heads crossing the elbow joint anteriorly, inserting onto the radius, so producing flexion. We had brachialis, and we also have another muscle not shown on this diagram called the brachioradialis. We have our main muscle group running posterior to the elbow joint, producing extension, and these are, as we're fully aware, the triceps. And we also have a little muscle called the anconeus, meaning elbow. So our triceps brachii, as we're aware, in the arm, crossing the elbow joint posteriorly, producing extension, and our little muscle here, the anconeus, which is a lateral stabilizer, so it can assist the triceps in producing extension, but it also is there to help provide stability for the elbow joint. And just to finish up, we have limits to elbow joint movement. So in full extension, we call this the closed pack position of the elbow joint, and this is limited, so extension is limited by the olecranon impacting on the olecranon fossa. So if we can see this section, this sagittal section of the elbow joint, our olecranon, when we're performing extension, it will be coming into contact with the olecranon fossa, or the fat pad that's placed in there, and that will restrict any extra extension movement. In flexion, so during flexion, movement of flexion is generally restricted by the soft tissue anteriorly, so our muscles of the biceps brachii and the brachialis found anteriorly. Thank you.